All right, I'm going to convene us. There are still chairs. Well, they can also stand, but there are chairs. Good afternoon, everybody. I'm Sandro Galea. I have the privilege of serving as Dean of School of Public Health. On behalf of the school, welcome to today's forum. This is our first forum of our new year as our students come back to the building. We are always delighted to welcome all members of our community to all our events. Today, in particular, I want to acknowledge two people from our Dean's Advisory Board, Zubin Shroff and Gary Cohen, who are here joining us. Thank you for being part of our school. Welcome to everybody who is joining us online. Just for those in the audience to know, generally speaking, we have about 200 to 300 people joining us online as well who are invisible, but who are watching from wherever they are. Thank you to Meredith Brown, Alicia Noel, who make these events possible. Last week was Martin Luther King Jr. Day. Dr. King, who is one of Boston University's most prominent alums, once said, true compassion is more than flinging a coin to a beggar. It comes to see that an edifice which produces beggars needs restructuring. At these events, we welcome speakers who address the structures that produce health, so we might reshape them to build a healthier world. Today, we're going to talk about something we've talked about several times before, homelessness, which we see as a core public health challenge. As a population, the homeless get sicker, die earlier, and have a harder time accessing healthcare than the rest of us. This discussion is part of an ongoing conversation we've been having about homelessness. In 2015, we welcomed Jim O'Connell, president of Boston Healthcare for the Homeless program, for a dialogue on homelessness. Our community, led by our activist lab, regularly participates in Boston's annual homeless census, including this year's census, which is going to take place tonight. And we continue to engage with the homeless that are part of our community here in Boston's South End. Our speaker today can guide us and illuminate this issue much better than most others. Anahaita Kotval is the Chief Executive Officer of Lifting Up Westchester, a nonprofit serving homeless and other extremely low-income residents of Westchester County. After more than 2 decades in the securities industry, she moved to the nonprofit sector in 2011 and served as Chief Operating Officer and General Counsel for Inspirica Inc., the largest provider of services to homeless individuals and families in Lower Fairfield County, Connecticut. She has extensive experience providing pro bono legal services to the nonprofit community. She is the director of the Pro Bono Partnership and received the Partnership's Volunteer of the Year Award in 2003 and Volunteer of the Decade Award in 2007. In all my conversations with Anahaita, I've been deeply struck by the fact that she has a real profound understanding of the challenges of homelessness and, as importantly, of how, on a pragmatic level, we can help alleviate the problem. I'm very much looking forward to hearing from her and learning from her. Anahaita.
Thank you very much. Sandro, thank you so much for the introduction. I'm not sure about guide and illuminate, but I definitely wanted to share with you some of our experiences as we've tried to serve the homeless in a community in New York, Westchester County, about 1 million residents, and we'll talk a little bit about some of the comparisons to Boston as well. So I'm going to make sure I can do this correctly. Okay. So before we talked about sort of solutions and our approach to solutions, I wanted to just set a common sort of ground in terms of how we're defining the problem of homelessness, who we think the homeless are, and how that informs our approach. I know some of this will be familiar to many of you, especially those of you participating in the count tonight. And so I wanted to really start with a quick overview of the numbers, some of the common myths that pervade those who serve in the homeless sector, and obviously the clients that we try to serve, and then to unpack the causes of homelessness a bit. And so just very briefly, and I'm not expecting you to read or review the slide, but I will send out the presentation later, and I just wanted everyone to be aware that for most homeless service providers, the PIT count and the count that you're doing tonight is obviously a building block of that count, is really the foundational data that we use to determine what the service needs are in our communities and what the resources are that are available in those communities to meet that need. And so this is the count for the entire US in January of 2019, which is created from the roll-up of individual communities. Boston and other communities in Massachusetts will roll up to a state number. All of the states will roll up into a federal number. It takes them about a year to process that data. So the January 2019 count is obviously our most recent count. And you won't be able to necessarily read it on the slide, but it gives you a lot of detail around where the homeless are being found, how many are in emergency shelter, how many are in transitional housing, how many are on the streets, which is what we call the unsheltered count, the total number of households that are homeless, total number of individuals in that household, and then breakdowns of families with children, single adults, and other sort of relevant characteristics, ethnicity, age groupings, people who identify as having a severe mental illness, people who identify as having chronic substance abuse problems, domestic violence, veterans, et cetera, et cetera. So the report is 2 pages. You can, the link to where you can find one for any community you're interested is up at the top of the screen. And I find it one of the most interesting things to look at when you're thinking about a particular issue, because you can get data from all different kinds of communities to compare and contrast. One thing in particular I just wanted to note, which is relatively new, is you see the 2 grade lines, unaccompanied youth under 18, unaccompanied youth 18 to 24. That is new data that they started collecting about a year ago. And there is a widespread belief that the number of unaccompanied youth who are homeless is unregistered and undercounted across the country, because the way that youth homelessness manifests itself doesn't really lend itself to a count. They're not likely to be out on the streets, nor are they likely to put themselves into shelters. Often they're sleeping in lobbies or with friends or moving from location to location. So that is one area that is now being focused on. So this chart just really summarizes that national count for the last 14 years since we started doing the PIT count, or the data started being reported publicly. And all it does is break it down between the unsheltered and the total number of homeless, and there's a percentage for the number of unsheltered. And what I really wanted to just have folks focus on this slide, and let's see if I can figure out how to use the pointer, is that if you look at this total number of homeless, you can see that the high point was in 2005, which is when we really started to track and to count. There was some steady downward progress for a period of time, and that continues pretty much through to today. There's bumps back and forth during the financial crisis, et cetera. But at the end of the day, over a 14-year period, we've reduced the number to still over 500,000 individuals at any given night in the country. To me, that is not saw a massive improvement given the billions of dollars and the significant amount of effort that has gone into homeless services during the same period. And if you look at the unsheltered number, the gain is even less so. And so the question I think that I want to spend some time talking about on this talk is, why is that, and how can we materially improve our progress? But before we get there, I just want to point out a couple of common criticisms of the PIT count, the point in time count. Providers will tell you, and it's true, that this is a snapshot of a single night in January. Some communities do a summer count as well, because during the freezing cold months, at least in the Northeast, it is very common for homeless individuals to hide themselves indoors in places that are not accessible to the counters, and that a summer count would be more reflective, because people would be outdoors, of what the actual census is on a given night. And then there's obviously the point that this is who's homeless on that particular day. It doesn't measure the number of people that might be homeless at other times of the year, or the number of people cycling in and out of homelessness during the course of the year. But even with that, that caveat, it is the best information that we have, and it's a relatively consistent information. And as I mentioned, with the focus on youth and other demographics, it's constantly improving in the level of detail and the communities that it's trying to access. So that's why it's the basis for our discussion. The most important group not covered by the PIT count are the unstably housed, or what we call the doubled up population, which are people that do not have their own home and do not have a stable place to live, but are living with relatives on the couch or borrowing housing from friends, maybe moving from location to location, or may just be one argument with a family member away from being kicked out of that apartment. And that number, is generally estimated to be at least the same number as those that are actually homeless today. But The point that I think is worth focusing on is even if you multiply the PIT count numbers by 7 times, some people say 3 times, some say 5, I'm saying double it and make it 7 times, it still represents less than 1% of the US population. And while on the one hand that's a really high number for the wealthiest country on earth, on the other hand, considering some of the significant public health challenges that all of you are talking about and discussing, it's a relatively small problem. It is solvable with our existing national resources if we wanted to solve it. And so I think one of the reasons that I chose to work in this field is it is attainable. And there's a gap between our ability to attain it and where we are. And I'm hoping this conversation will convince you that we can get there if we focus on it. So the only other thing I wanted to just flag for you for, whoops, there we go, is I just broke out for you here, there is another report, which I didn't bother to copy for you, also from HUD, which will provide you the inventory of beds and services for the homeless in any given community. It's at the same website, it's a different report, it's called the Housing Inventory Report. And again, for every community that counts its homeless, they also count the available shelter and other beds. And for 2019, across the country, there were 389,549 shelter beds available. That's shelter and transitional housing. And you can see that the total number of homeless counted was 567,715. I live in a community, and I'm going to show you the Boston community, where there is actually an adequate number of beds. But obviously, across the country, that is not the case. And part of that, and you'll see if you add the total unsheltered number from 2019 and the gap between the number of homeless and the number of beds, there's actually still more people, there are beds available for some of those unsheltered people. And obviously what that reflects is geographic differences, right? We may not have enough beds in San Francisco, but we may have beds that go wanting in Kansas City. So that's an important topic, because when I'm talking about serving the homeless, we'll talk about the fact that your community needs to have enough beds for everybody not to be on the street, but I'm operating in a community where that is not our primary problem. The problem is either getting people to access those beds or figuring out what to do with them once they're in shelter. But that is obviously a gap that we should all be advocating for in every community. Okay, these are numbers I just looked up quickly over the weekend, just for your information, from your state and the Boston Continuum of Care. You can see the homeless numbers are peaked in 2018. They've dropped a little bit in 2019. There's been a steady effort to increase beds, about 5% a year, which is actually pretty good. Many communities are actually dropping the number of beds. And if you look at the Boston Continuum, your homeless numbers have been pretty steady, and there's again a modest increase in the number of beds. So again, Boston actually is similar, according to this data, to our Westchester experiences. You really have the beds that you need. There's obviously a modest shortage, but if you have more than whatever that number is, 70 to 90 people on the street, then your issue is not the supply of the beds, there's something else going on. So, common myths about homelessness. And I want to spend a little time about this, although I imagine I'm preaching to the choir in this group, at least from the students I spoke to this afternoon, because I believe that our beliefs about why people are homeless affect the way that we serve them, and are part of the reason that we haven't made more progress on this issue despite 20 years of attention at federal, state, and local levels. And so I think that, at every aspect of how we think about why people are homeless, we're handicapped by our predisposed notions of how they got there. And that's whether you define the problem as getting them off the street versus getting them back in their own homes and living independently. That's whether you think the resources you need to assist them are facility-based and security and safety-based, or therapeutic and advancement-based. And it's what you think they deserve as the end result of your intervention. Is it just being free from injury and harm, or is it a thriving, successful, full life? And similarly, once we get them stable, is that the end, or can they aspire to greater things, which is obviously all of our, human goal and interest. And then lastly, and what I'm really going to focus on primarily today, how we serve them. Are we thinking of short-term palliative care? I think of a shelter, it's an ER. Or are we thinking about a long-term investment in solving whatever their challenges are so that they can have a future that does not include cycling in and out of homelessness? So, the myths. I'm 52 years old, so this was the myth that I grew up with, which is that homelessness in America is a late 1970s problem caused by the closure of mental health institutions in the 80s and 70s, and that the homeless are basically all mentally ill. That's the argument or the narrative. The reality is there are 100 million people homeless across the world, so it's not an American problem and it's not a modest problem. Documented homelessness in the US has been a national issue since the 1870s, since the Civil War. And after the Great Depression, 2 million Americans were migrating and homeless throughout the United States due to the economic disruption and the search for jobs and search for homes. And all over the world, every time there's an economic or a conflict-related disruption, homelessness is created. The 1960s deinstitutionalization of mental hospitals did introduce a material number of people onto the streets as homeless because there was no planning of where those folks were going to go. I think most providers would agree that the deinstitutionalization had many positive, intentions, but there was no plan for what was going to happen after that. But I'll show you in a minute some of the numbers. It's not the C and not the cause that I think many people would like to, attribute to it. 1980s cuts in the housing and social service programs that were started after World War II and continued through the Civil Rights era also obviously affected the availability of affordable housing. So you had the two things happening at the same time. And then these are the numbers from the PIT count. 20% of the homeless have a severe mental illness compared to 4% in the non-homeless population. Just for reference, 70% of those in the juvenile justice system have a severe mental health diagnosis, 41% of VA patients, 37% of those incarcerated, and 7.5% of those living below the poverty line. So what I take from these numbers, you guys are the public health experts, is that while mental health is certainly a co-occurring disorder, is certainly a comorbidity of being homeless, it's not significant enough as a percentage to argue that it's the cause. And in fact, these other vulnerable populations, higher percentages suggest to you that the homeless, like other vulnerable populations, are more susceptible to have an incidence of these instances, but it's a stretch to say that mental health and mental illness is the cause of homelessness. And then the other thing that I have learned from my colleagues since I started doing this work is that being homeless, and particularly for those who are living on the streets for extended period of times, is itself something that can cause or trigger mental illness. Mental illness that you may already have had, that may have been stable, but frankly, for people who have never had a mental health issue, being in an environment where you're not safe, being in an environment where you've been separated from everything that you associate with your identity, your family photos, your friends, your neighborhood, your most precious possessions, your clothing, is an extremely traumatic event and creates some of the behaviors that we see in people that are on the streets. So again, there's a cause and a effect question there about whether they were mentally ill before they were homeless or whether their prolonged homelessness either aggravated or caused the mental issues that they're suffering. Another pretty common thing that we hear, even from our generous supporters, people are homeless because they're drug addicts. Again, I think we know there's a huge opioid and other drug problem in the United States. Not everyone who is addicted to drugs becomes homeless. It is clear from these numbers that there's a higher incidence in the homeless population than there is in the general population. But again, 16%, 20%, these are not numbers that suggest a direct causal connection. Another thing we hear a lot of is people choose to be homeless. And this is one that I think even people that work on our staff sometimes fall prey to. When you are an outreach worker and you're going to help someone and you say, please come to our shelter, ours is called Open Arms, and you give them your card and you say, come in and we'll give you a meal and food, and they refuse to come, it plays into this belief, right, that they choose. But a more sophisticated analysis from folks who have been doing this for a really long time is they choose not to come into shelter because the choice that you have given them is for some reason less attractive than the choice of staying on the street. And our mission really is to figure out why it's less attractive. And there is a significant relationship to the whatever trauma they may have faced in other institutional settings, in situations where they've had to take public showers, in situations where they've gone to a shelter and been required to be on medication, that if you don't inquire into, will shut down any dialogue about how you're going to help them and how to move them forward. And we'll talk a little bit about some efforts we're making to do a better job of that. So I think, I think it's just a question of how we define what choice really is. And then lastly, we hear this a lot in Westchester because we're near New York City, and obviously New York City has a huge and not well-addressed homeless problem. If we didn't provide assistance, we wouldn't have so many homeless. And there's quite a movement, actually. If the shelter's not in my area, if we don't, humor and entertain the homeless, if we're strict in enforcement, then we'll solve this problem in our community. And the reality is that the homeless actually congregate not because there are services. They congregate in places where it's easy to go undetected, where it's easy to get access to free food, to people who are going to give them something to assist them, to public transportation, usually to places that are familiar to them. So it's not a surprise that cities tend to be more popular. And you don't find the homeless in Tony neighborhoods because they're more not noticeable and they're not going to blend in, but you will find them in a downtown area of a city where if they're standing between buildings, someone might not make an issue of it. So, and then the other thing is that it is factually untrue, I think in almost every community in America, you cannot get services if you're homeless, if you cannot prove that your last residence before you became homeless was that community. So, governments have figured this out, and nobody wants to be serving someone from someone else's jurisdiction who came to their jurisdiction because it was better or kinder. Everybody has eligibility rules, which can be frustrating as service providers. You need to be able to document that Westchester was your last county of residence or Boston was your last county of residence. There are some nonprofit providers that will take people from other states, but it's a fairly geographically controlled thing, so also not a true statement in most cases. And then not so much a myth, but I think a perception that I think can be common, and particularly with the current political environment, that everybody who's homeless is an ethnic minority. And while it is true, as in many things like poverty and violence and other things, that there is a higher representation of underrepresented minorities in the homeless population, in terms of the makeup of the homeless population, you can see that it doesn't discriminate. There are, major numbers of people from all ethnic groups in the homeless population, and there's not an exceptionally high number of undocumented individuals, and that could be fear and the fact that they don't want to come forward and be counted because they're worried about consequences. We have a sense, at least in Westchester, that it's also cultural. Recent immigrants have that support system where they're used to taking care of each other and allowing people to stay and sleep on their couch. But in any case, the notion that most of our homeless resources are being diverted to people who are undocumented is not factually accurate. And then lastly, just for context, 25% of the homeless, this is across the nation, are regularly employed, meaning regular, consistent employment. 40 to 60% float in and out of employment throughout the year. 25% are veterans. 41% are single parents with children, and 8% have experienced domestic violence, which is a little more than twice the average for the rest of the population. So, if mental health and drug abuse are not the cause, what is the cause? Our belief is that at the end of the day, homelessness is an economic problem. It's the simple problem of my earnings do not equal what I need to be able to pay for rent in the place that I want to live, therefore I am homeless. That is the foundational way that I believe we should be thinking about this issue. The other complicating factors that might lead to why I can't earn enough, my poor education, my history of incarceration, my mental health, my ability to remain sober, those are all legitimate obstacles that we have to address, but it's not the cause. The cause is fundamentally the same. And it's the reason why we have families who are working full-time living in shelters. We have people who have had 30 years of careers as nurses and professors and people who are homeless. And if people understood that better, I think it might change our view of what they deserve and what the level of our intervention should be. So poverty alone can't be the cause of homelessness, because we have 100 million people in the United States living below the poverty line or just above it. So, and we have, you saw a much smaller number of people that are homeless. So, our postulate is that it's the intersection of poverty with a crisis. Could be a family crisis, could be a job crisis, could be a health crisis, could be a mental health or other episode, loss of a loved one, end of a relationship, whatever it may be, and isolation. Not having a network of family like all of us would have, because we all have those same crises, but we have family to fall back on, and maybe even a safety net and a savings account or a family member to bail us out. So when those three things intersect, some of those 100 million people who are already living right on the edge fall into homelessness. And that's, I think, where the homeless service providers need to think of themselves. That's the gap we need to fill. We need to provide that support that they don't have from their natural, friendly, and family community. And that can be financial, but it's also as important, the moral support, the coaching, the encouragement that they need to get back to where they need to be. And then, I just would mention that there is a failure of other systems that contributes to the homeless problem directly. The things I talked about before are how people lose a home and end up homeless. But there are systems that create homelessness. So youth aging out of foster care, you're kicked out of your foster home. There's no plan for where that young person is supposed to go. They don't have a job, they're homeless. When people are being released from prison, some prisons are doing amazing work in doing the pre-planning and the community re-engagement. Most are not. We have people brought in handcuffs to our shelter, 8 o'clock at night, no warning, no explanation, no plan. Probation officers coming back in 3 weeks. So has to be addressed and has to be fixed. And then, of course, the discharge planning from hospitals and psychiatric institutions, I think, is a commonly understood problem. And then, of course, failing schools and all the other societal things that we all know about. So with that background, what is our goal? And I think we at Lifting Up Westchester have really tried to define our goal to be permanently exiting people from homelessness, to go for the long-term lasting solution, not just the bed night, not just the meal served, but a permanent exit from homelessness. That's the win. The rest of the work is important. We still don't want people freezing on the street. We still want to make sure everybody's taken care of and safe, but we shouldn't be touting success unless we permanently place someone in housing. And so same thing, I want to just give you a quick overview of the economics behind that thinking, sort of our approach, and I call it some success stories because we are a $14 million agency. We serve about 3,500 people a year. So it's not the kind of success that your data-driven studies and analyses would require to be confident that these interventions work, but they've materially improved our outcomes, and so want to share them with you. Some of them are quite preliminary. So the numbers. There is a professor at the Wharton School called Dennis Culhane who for many years has done research on the cost of keeping people homeless. And his analysis, and I summarized it in a much simpler way, it's an amazing paper if you want to read it, and he did this in the 1999 to 2005 in New York City, with the cost to keep someone homeless. And what I mean by that is living in the shelter or living on the street, the service costs, the policing costs, the emergency room costs, the in and out of the criminal justice system costs, security, whatever it might be. And he estimated that it was $40,000 to $85,000 a year. By the way, this is 10 years ago, but both numbers are from 10 years ago. $40,000 to $85,000 a year to manage a chronically homeless individual. The range has to do with how high needs they may or may not be, with all of those costs. On the other hand, if you were to give a housing subsidy to someone who was in that shelter, same chronic need, and he's talking about permanent supportive housing here, the housing subsidy, depending on where you are and if it's a single room, would be between $10,000 and $25,000 a year. The math is pretty obvious. We took the mean. You save $45,000 a year on average for every person you move out of shelter into permanent housing. And I find this to be a really staggering concept because I think it answers the question for some of people in community who do legitimately ask the question, you want us to give a permanent housing subsidy to someone who may not be working, may not be mentally stable on their medication, may still be a substance abuser. Why is that fair? I have to work, or my friend has to work, or whatever it may be. And the answer is, regardless of how you feel morally about that, it makes economic sense. You're taking care of them anyway. You're spending those resources to take care of them anyway. You're just doing it in a more expensive, substandard, less humane way than if you did it this way. And then we'll talk about some of the stabilizing influences of that housing on other things and other aspects of life. So this is our perspective. These are hard numbers. There are some studies that have been done that have tried to capture the soft numbers. What happens to a community when you reduce the number of homelessness? What kind of corporate investment do you get in your downtown area? How do real estate values improve? What happens to retail traffic? And I didn't quote the numbers because they're not rigorous in the mathematics of the numbers. They come up with very high numbers, but the concept I think holds and I think is intuitive to all of us, which is the community does better when it doesn't have a visible homeless problem. So that's sort of the economic case. Children, homeless children. Homeless children have, you all know the statistics on children growing up in poverty and with trauma. Homeless children, just take any statistic that you're familiar with and double or triple it. It's just worse. Their teenage pregnancy rates are worse, their suicide rates are worse, their high school graduation rates are worse, their lifetime health outcomes are worse. And so investing in homeless children to make sure that they don't become homeless adults is another place where it makes sense to do it right and to do it early instead of spending money on the back end to try to fix things after the horse is already out of the barn. And I just gave you some examples there. And there are so many studies that talk about, every intervention with children, early childhood education, mentoring, whatever it might be, very important to capture. And these children are truly a captive audience because we know where they're living and they're already in facilities where it's easy to deliver services. So that's the practical case for why we should care about this and why our solutions should be permanent. I wanted to just spend a minute on approach because what works for us is not going to work for you or organizations that you're involved with. A lot depends on funding streams and your local community and geography that I wouldn't pretend to understand. But I do think that the philosophy might be transferable to this issue and potentially to other significant social issues. So service interventions should be informed by data analysis. This is something that I don't think the nonprofit sector, not universities and hospitals, but the service provider sector is particularly good at. We're not funded to do that kind of analysis. That's not the skill set we look for when we hire people. We're looking for that compassionate person that can talk someone in off the street. We're not looking for someone who can run an Excel spreadsheet and run data. And so data for us is usually a punishment that a funder gives us for giving us money. And so we do it kind of half-heartedly and late at night in addition to our day jobs and hope that it passes muster. We rarely take the time to think in advance, what are we trying to show, what would help us? But I think there's tremendous potential for funding if we can do it well. And honestly, the hospitals where we are have been real leaders in this and really helped us in a couple of ways that I'll show you about. But I think it has to happen because I think it stops nonprofits from getting so caught up in how hard the work is and how good their intentions are and how necessary that short-term intervention is for the survival of their clients, that they don't focus enough on whether they're doing the long-term work. And the data really helps you, I think, reach clarity on that. The other thing is every time you give someone a transactional service, and for us that's a bed night or meal served, treat that as an access point to build a relationship that's meant to be for the long term. And that is exhausting. And it's resource intensive, and particularly with people living on the streets, I've had staff give us stories of years of engagement before they've made progress. But that is how the work is done. And so figuring out how to co-locate or use your points of access to get people into a longer term intervention, a better program, I think is really, really important because we have the access points and we have the patients. And there's so many services out there that want that, but don't know how to access them. We got to figure out how to partner those two things. And then have a diverse set of funders and partners to maximize your flexibility, your independence, and your expertise. The government funding is very valuable because it tends to be stable, current political situation, notwithstanding, and there's a momentum to it. Once you get a government grant, you have to do something usually to lose it. And so you can breathe for a moment. You're not raising that money every month or every year like you are private funding. But it comes with strings. And some of those strings are financial, what you can spend and what you can't spend, but also who you can serve and eligibility requirements. And it's very common for nonprofits to find that, wow, if you only had HIV, I could give you this, and if you were a smoker, I could give you that, but you, I can't help, even though I have the intervention that's needed to kind of assist you. So you really do have to have other funding sources if you want to be able to help the person that presents themselves to you, rather than cherry picking people that match your individual program requirements. And that's obviously can be private funding, but private funding can also come with a lot of strings. And in our case, some of our community partners have really proven to be better sources of funding for that, and I'll talk a little bit about that later. But having that independence is very, very important. And then, last but not least, don't settle for the easy win. It is very hard to run a shelter. It is very hard to run an outreach program. It is easy to just say, wow, I didn't run a deficit. I kept everybody safe. We've dropped the number of people that are living on the streets. But again, if they're still in shelter and living in this sort of nomadic kind of existence, and we haven't figured out what they're going to do next, we're not done. And it's not really okay for the homeless services sector to define the win as we swept people off the street. That feels like it's more about serving all of us for not having to see the homeless problem than it is about serving the individuals themselves. So to push yourself to constantly think about what you can do better. So the service model that kind of goes along with this, and by no means do I think that every nonprofit should do this. I think the message is your community of providers should figure out how to do this in order to have wraparound services for the homeless. So as we talked about before, how many shelter beds you have for the peak sort of homeless volume you have is important, because if you literally don't have enough shelter beds and your strategy is to arrest people who are homeless, you're in trouble. That's not going to work. But for those communities where you have the beds and you still have people living on the street outreach is really important. And it's something that I think very few communities do well. I think we are just starting to do it better in Westchester, and we do it with a number of other providers because it's a big county and you can't have one agency trying to cover it. But it has to be relationship-based. And for those of you who've ever worked in business, literally like the ad agency that covers your account, you need to know where the street people, and they tend to stay in the same place. People need to know who they are by name. They need to know their habits. They need to know where to find them on a really bitterly cold day. And they need to be checking in regularly with them like a relationship manager and building that rapport and understanding what their challenges are and tailoring a very specific thing to assist. Now, that's not overwhelming in Westchester, where our number of unsheltered is between 35 and 50. You can do that. Looks like your numbers are not that much higher. But obviously, if you're in LA, that's a much more overwhelming challenge. But it is still the only thing that has been proven to work. To expect that you can walk up to someone and invade what for them is their personal space, their living space, and say, come on. And if they say no, wow, well, then they don't want our help. It's just not a realistic interaction, and it's just a waste of those outreach workers' time. So we really have to think about it in a more strategic way. And then lastly, philosophy. Entry into shelter should be the starting point of a journey to get the person out of shelter and back into the community, not the end goal. And again, we're all beleaguered, we're all under-resourced, we're all tired, and the work is really hard. But if we don't maintain that as the mission, if the mission becomes about shelter, if the shelter staff think of themselves as shelter staff and not housing staff, then you get into the situation where we're warehousing poor people in shelters, but not figuring out what an off-ramp is. So that is shelter-rich environment. We talked about that. You need to have resources and off-ramps to other services that people need. I don't believe that you should make your shelter a mental health facility and a drug abuse facility and a massive mega resource center. I do believe you need to find ways to bring those resources on site. Our experience has been that anytime you require a referral or a handoff, you lose compliance. If you give someone a slip to go to mental health treatment 3 blocks away and you're not walking them over there, 17 things can happen from the time you gave them the slip to when they got over there, including confusion and just not knowing what to go and what to ask for, but also noncompliance, anxiety, fear, whatever it may be. So the more you can do things in a way where you can control them, when you can ensure a firm handoff, the better off you're going to be, and finding those partners is really, really important. And then aftercare. And this is unique, I think, to the homeless sector, where so much of our assistance is shelter and facility-based. Once we place someone in housing, there's always a little party, and there's a furniture kit and a welcome kit. And then usually the money for services stops. Unless you're in supportive housing where you have a chronic mental or substance abuse diagnosis, your case management dollars are over. That's a tremendous vulnerable time for our clients who have sometimes been institutionalized for years before that moment, and now are expected to deal with the loneliness of not having people around, figuring out their food, their transportation, the behavior in a new context, all of this with absolutely no disposable income after they pay rent to go to a movie, make a friend, take a class. So it's very important to have that aftercare, and we'll talk about a creative way we found to fund that. So, and then working with community partners, we sort of talked about this, about the handoffs and the gaps in services, talking to your local police department, talking to your local emergency room, so that when these discharges happen, there's a plan. When you have someone that you cannot serve effectively because of an extreme mental health or substance abuse problem, you know where to send them, and the community is willing to serve. And I say here, because we had a conversation with some of your colleagues earlier, we are not there on this in Westchester, and I suspect in many communities around the country. We have so much goodwill and so much resource available, but people are constantly getting dropped between the different service systems. The communication is not what it should be, and it's something that we're working very hard to focus on. But again, it becomes part of your mission, even though system design is not really part of our mission. You can't do your work unless you can figure out how to get your clients, to someone else when you are not able to serve them effectively. So this is just, our 4 program areas. So I wanted to just talk about 3 examples of where we tried to apply this approach. And this one is still early in its kind of in its infancy, but we run a very large soup kitchen out of a church, 40 years old. We serve 60 to 80 individuals, usually single adults, a daytime meal. Place is open from 10:30 to 12, and we pay rent to have it all day from the church. And when I first joined the organization, there was a lot of pride from the staff that people had been coming there for decades, that they felt comfortable, it was like their second home. And we started talking about, it's very disturbing that someone needs to get a meal at a soup kitchen for decades. I mean, that means we're not addressing the underlying problem. And so we didn't know a lot about who the people were. It was a traditional soup kitchen. You come in, you get your meal, nobody asks you any questions, and there's a lot of reasons why you don't want to ask questions. But we decided to put a case manager there, and we put someone who was not credentialed but had been doing this work for decades. She goes there in jeans, and she just started sitting and having the meal with folks and chatting and getting to know them. She's an amazing individual, very gregarious, very trustworthy. And she started to learn about these people's lives, and the information here is pretty much anecdotal at the moment, but we've had about 12 cases where a very small intervention, advocating for someone to get their veterans benefits because he had a mental deficiency and didn't understand the system and therefore was denied, or reuniting someone with their family in Tennessee but they needed a $300 plane ticket, or going with someone to get their birth certificate from an abuser's house so that they could qualify for benefits, made a difference in them needing to be there and being able to be, on a path to living a normal life. So we're now trying to step that up with some data. We've gotten these barcodes that have no identifying information, just a number, and they'll check in and out, and they'll give us demographic information. We'll have a better understanding of who we're serving and what the issues are. But it's just an example of how, with a little extra investment and a little different approach, you can maybe permanently make a change for folks. And this is something where We are now starting to work with our local hospital to do a health and wellness program at the soup kitchen because they obviously have a mandate to serve this very hard to serve population. They're bringing mobile health vans to do health screenings and diabetes screenings. And the beauty there is they will then have that data, which we would not have access to because while we know when we send our clients for care, we don't get the outcomes data of what their health outcomes are. So the hospital will track that for us and we'll hopefully be able to learn whether there's been a material improvement in their physical health as well. What I really wanted to talk about with you today, though, is our housing retention program, because housing retention is nothing new and exciting. I didn't come up with it. We're not the first people to come up with it. But it's a concept that basically says if you put a person in that apartment and you want them to stay, they need help. And you have a case manager whose job is to keep them stable in their housing. And so we didn't have that at Lifting Up Westchester. Our funding ended when the person left the shelter. And I was not successful in convincing the county government that funds the shelter that this should be a standard service that was available in the shelter, both to help clients find housing, which is very difficult in an environment like Westchester with the high costs, but also to stay with them and help them progress. So we started talking to the local hospital and for a different reason, and they were asking about service gaps because they're very interested, obviously, in social determinants of health. And we explained that our vision would be that just the way someone in supportive housing has, in their case, a lifetime case manager, we didn't think our regular shelter residents needed lifetime support, but they did need some transitional support, just like the supportive housing clients, someone to help them negotiate the lease and help them learn what the rules of the road were and teach them about housekeeping and budgeting, and when they get themselves in trouble on the rent, not hiding from the landlord, but taking it head on, et cetera, et cetera, et cetera. And so working with the hospital, we, through Medicaid and innovation funding money, put together a pilot where we hired that person with their funds and also hired a care manager from, which I don't know if that term is only a New York term, but the concept is someone who helps people enroll in Medicaid and manages their more difficult cases, which our clients qualify for, that would be located on the site of the shelter. And we would work with everyone, even those people who are non-compliant with shelter rules. So even if we kicked you out of the shelter upstairs, you could still come and meet this team during the day because it was privately funded, and they would still help you find housing. And so the results of that have been that program's been effective since February 1. These numbers are from November, but we've placed 75 people in housing. Every single one of them is still housed 10 months, 11 months later. Some of them it's only a month later, compared to a 35% return rate for the control before we had this program. Obviously, we need to do this for at least another year because some of the people haven't been housed very long, but we are very confident that it is working. And then speed of placement has increased because you have a staff person whose only job is to focus on housing, not on all the other things that our clients need, which their regular case manager is working on. But more interesting, perhaps for all of you, and I think for our funders, the fact that they were also linked to this care manager who made sure they were linked to care in the place where we placed them in housing so that there was a smooth transition of all of their medical and other services has resulted in a decrease in emergency room visits from, I think, I'm looking up there, I think it's 60 before, in the 6 months before the intervention, and I think it dropped to 5, I don't know where I have it here, but it's on there somewhere. Yeah, 5 in the 6 months after. So huge cost savings for the health system, which is obviously what the hospital is focusing on. But for us, what it did was, it not only gave us a chance to pilot something we believed in, which now the county is wanting to take credit for and willing to think about funding, but it allowed us to have the data to prove it. I mean, I can say that less people came back to shelter, but the hospital's access to the medical data allows them to show the actual material cost savings of that, which I would not be able to replicate on my own. And so I just think it's an example of where if you find the right partner, you don't have to do everything yourself and you can still kind of get where you want to go. And then the last thing I just want to mention is our youth programming. And this program, interestingly enough, has always been designed the way I described. This is not something that we rethought as a result of our new approach, but it was probably the trigger for our new approach. And basically, it's so simple, it's almost embarrassing. We have 2 large cities in Westchester where most of the homeless come from, and under the McKinney-Vento Act, children are allowed to remain in their home jurisdiction when they go to school. So they have the primary number of homeless children in the school, over 400 kids in the 2 schools. and partnering with the schools and the social workers who are required to be in the schools under McKinney-Vento Act. We have after-school mentoring programs, and we basically are on the school's grounds, their resources. We hire their teachers to put in after-school hours, and we offer everything from literacy programming for the younger children, reading and fun games, they don't know it's a literacy program, to middle school kids, kind of STEM, career exploration, after-school help, again, fun and very light touch. And in high school, it's a full-on, what I call a yuppie, academic prep program, SAT prep, PSAT prep, TOEFL exams, Regents prep, what do you want to be when you grow up, college visits, FAFSA form completion, et cetera, et cetera. There's nothing but the teachers and a big room. Pizza, food is often our biggest lure because a lot of these kids are hungry. And they work their way, some have been with us from age 5 through their graduate school accomplishments. Others, we get them in 8th or 9th grade, and they don't really take off till 10th or 11th grade. But we have a 100% graduation rate from our high school seniors in a public school that has like a 50% graduation rate. And so it just shows you that if you give people the right intervention in the right place, it's not about the dollars you spend, it's just finding out what works and what is easily accessible for them. The beauty of this program is whatever is going on with the parents, the good ones who are just preoccupied with finding housing and employment and just can't focus on their children's education, or the ones that are struggling and really are neglecting their children, they're not relevant to this because they're already at school, they're already at the library, we do it in a couple other places, some of the family shelters, so it's the parents have to consent, but the parents are not part of the picture, and it's just extra. So I just want to leave you with that because of all the things we've talked about, the right partnerships with school districts, I think this is a very easy thing to replicate. There's no technology to it, there's no curriculum, it's just a concerned, caring adult helping the children build a plan for their future, which I think all the psychological research shows is what's limiting children living in poverty. They don't have the ability to think about a future that's different than their present, and they need a strong adult figure in their life to help them make that plan and then to stay with them from cradle to grave until they get where they want to go. So with that, I do have for you guys a couple stories, but I won't go through them all. But this young lady grew up in a very traumatic situation. When her grandparents died, she had to go back to live with her mother, who was a chronic substance abuser. Situation was so bad, we helped her get emancipated at age 15. She's now a lawyer, opened her own firm, just bought a house in Rockland County, comes back and teaches in our summer camp. We have someone else who's on his way to medical school. So my only point is the opportunities are limitless if we give people the right help and the right support. And I don't think everyone understands that a young lady who grew up in these circumstances could be who she is today and be a role model for other young people. And then from the housing retention program, this is an individual who had been living on the street for a long time, who was enrolled through the housing. He was not compliant in the shelters, so we had to keep kicking him out of the shelters, outbursts with other clients, other problems. We served him through the housing retention and care management program, and he's now caring for another family member who's ill. He's trying to get his certificate as boxing. He's living a very productive life at the Y. So again, not everything is as it seems, and most of our clients can get to a point where they're thinking about other things besides where their next meal and where their next night's sleep is from. So with that very long preliminary, I just kind of wanted to open it to questions and whatever anybody wants to ask.
Hello, thank you so much. Oh, I'm loud. Thank you so much for being here. My name is Rafiq. I'm a student here. Earlier in the talk, you kind of showed the representation by race, and I was a little confused because you said that you said homelessness does not discriminate, but the data that you showed kind of showed exactly that, because if you take the proportions of saying 40% of the homeless population is black, but it only represents 11% of the entire U.S. population, and 40% is white, with 70% of the population. That to me is showing exactly that the proportions don't match at all, and so that there is.
So I probably said that badly. I think what I'm referring to is, I think from the pictures that we use in fundraising, from the social narrative, I think the perception is that white people don't become homeless. I think the perception is that, amongst some, is that it's underprivileged minorities who didn't do what they were supposed to do. And I think all I'm saying is when 40% of your homeless population is white, it sort of disabuses you of that notion. I think the discrepancy, and the reason I highlighted it, is African Americans being so much higher than the percentage is more consistent with what we know about the fact that there is a higher incidence of other social injustices that make Black Americans have many other health outcomes and other things in a higher percentage, but it's not, 95% of the homeless population is not Black and Hispanic. And so when we're serving people, the challenges we have, they're the same across the board. And I think most people are surprised that a third of the people in our shelters are white. So I meant it more from, I think the perception is much worse than these numbers. And the reality is they really just reflect the overrepresentation in every vulnerable bucket of the underrepresented minorities. Interestingly enough, the Native population you saw is only slightly higher than its representation, and I think that's just because of the whole reservation. It's a very different economic, where a lot of Native Americans are on the reservation, and so they're not in the mainstream homeless system, so that's probably underrepresenting the problem there. But, and I think for Hispanics, it's partly fear for people who are concerned about, being exposed, and partly the cultural dynamic I mentioned, where I think there is still a early generation immigrant support structure available to them that may not be available to people who've been here longer.
Thank you.
Please.
So I have a microphone. I had a question about the retention timeline. So I work at Boston Healthcare for the homeless program, and we have a lot of patients who get housed, and then there's a period of destabilization where they actually feel more isolated. They have trouble with managing what is rent and budgeting and all that kind of stuff. And we'll have patients who'll come back a year later, after being housed, being fine, then they're behind on rent, they're facing eviction, or there's issues with isolation and their substance use goes back up. And this is issues that come up after 12 months or so. So I noticed that your follow-up period was 6 to 12 months. I guess I was wondering, if this is something you guys are worried about, because the whole point is to end this for good, right? But it seems like a lot of things can show up, even post 12 months, 2 years later, or so.
So the data on housing retention programs, and this is true for employment retention also, which is a piece we're just starting, is if you make it past a year, your chances of making it are multiples. I don't have the numbers at my fingertips. So that's kind of why we use the year. And there's also just a practical aspect of, our resources. So we'll know more as we do more. But I think, things like isolation, for example, part of the housing retention case manager's job is not just to worry about furniture and food and access to transportation and healthcare, but to help those people identify, so if they can't work, social connections, volunteer opportunities, to plan for, hopefully, not having that isolation. The one that is trickier is the financial exposure, because even if we stabilize them in all the social and health and other aspects of their living, they're still extremely low income. And that's why we're focused so much on this employment piece. But as you know, the relationship between employment and benefits is complicated. We're not going to be employing people so that they're now making $45,000 a year. They're going to be making $25,000, $30,000 a year. And at least where we are, and I suspect where you're working, that's precarious living. So that I don't have an answer for. The goal would be that, having had a housing retention manager, having been taught how to access services in the community, they would be more likely to reach out for assistance and for help, whether it's to us or one of the other resources we've introduced them to, rather than what is the more typical behavior, which is kind of ostrich in the sand. I'm starting to panic, and I just wait till I'm back in a shelter again. But it is a very real concern. But I think the hope is, as I said, that you're building these protective resources and communities so that they have the best chance possible of not having that. And that's intensive work. So, the idea that we would be able to do that with the existing shelter staff was not realistic. Yes.
Hi, I'm Ashley. I'm a current MPH candidate, and I currently work in the public health and legal pro bono field. And one of the biggest financial changes in circumstances that I have dealt with comes at divorce and separation. When an individual is faced with a new situation where they have to provide for a family on their own that they previously had a partnership with. And I remember reading one of your slides, and single parents contribute to 40% of homelessness. And I was wondering what you thought of using a more common term in public health, an upstream approach, with creating some sort of policy change or working directly within the judicial system to find some sort of agreement at divorce and separation between the two parties that would make this financial transition easier, so that many people wouldn't fall into the situations that I commonly see. And maybe if you saw within your experience in your field, if there's a better way to work in the public health perspective into the family divorce system.
So I think it's a great idea. I think the challenge I would see with that is with the exception of the domestic violence arena, where you have people with financial resources who nonetheless have to leave whatever resources are available because they just cannot engage with their abuser, and so they can find themselves impoverished even though the family has resources. I think in most of the cases, and we absolutely have a lot of single women who are there because of a bad breakup or the death of a partner or because they left a difficult situation, the partner has no resources either. So I think the concept is right. I am just not convinced that it's because the other partner is waltzing away with a huge cache of resources that would be available for the family. I do think better enforcement of child support and all of those things which come when you have a low-income population that doesn't have good access to legal services can help. And many of the family shelters do that. We don't operate a family shelter, but many of the family shelters do provide that kind of assistance. But I think the concept is right. I think that what the intervention might be might limit the improvement, but it would certainly improve, outcomes to a degree. Yes, please.
Hi, I just wanted to say thank you so much for coming to talk about this problem that we just see right when we walk outside. My question is, I kind of struggle with this as a public health student as well, because we talk and focus a lot about population level health issues, and I know you said something about supporting the community is something that we need to focus on as a relationship level and know the people's names. So I'm kind of struggling with how do you bridge that gap between a population public health issue and an individual one as well.
So it's easy for us to say because we do everything at the individual level, but what we've done in Westchester, because outreach is such a local issue, you need to know the community, you need to know where people congregate. All of the homeless service providers have an outreach call every week, and we all report on who we've seen on the street in our sectors or complaints we've gotten from the police department or the mayor's office or whatever it may be about people that are loitering, and we literally come up with a plan. And that plan can include that, my person is a Hispanic female and this person in Yonkers is a female, so she's going to go do the outreach in Yonkers even though we're White Plains based. But it can also just be getting ideas, strategies, interventions, getting a mental health professional, whatever it might be. And that does work. The size of the population really matters, and I guess my answer would be if yours is a very large population, then you cut your grid differently, but you still treat it as a local relationship-based program, but maybe there's just that program for people in these 4 blocks, and you let the other 4 blocks do it on their level. This is one of the hardest things I think in homeless services, and the collective experience of our partners is if you don't deliver the service in that one-on-one way, and it still takes years. You can't build the trust that's needed, and these are folks that have had a significant erosion of their trust, if not a diagnosable paranoia, anxiety, whatever it might be. And so it's not a great answer, but that's, I think it's just break it down to a human level and figure out how to cover it. And what we have found is if we only have to cover a certain terrain, then I have staff that can do that on slack times, right? It's not a full-time job. You're not going to wander the street all day. So it's easier for us to cover the terrain if we all do a little bit. Yes, please.
Called the Mobile Medicats. Oh, this is weird. And what we did is we went out to parks to provide care packages for the Tucson homeless population. And the biggest thing that we were trying to do was looking at how can we get these individuals enrolled in these like Medicare, Medicaid, or any of the the big relief programs. And the biggest problem we came across is, like you were kind of talking about, like helping someone go to the house to go get a birth certificate. When I have individuals here who are facing a lot of issues, including homelessness, immigration issues, like extreme poverty, and they don't have those documents anymore. How do you bypass those situations, or how do you even navigate them so that I can get them aid?
So this is my personal opinion, not as someone running a homeless shelter. I think that anything anybody wants to do as a volunteer to engage with people who are homeless and on the street is wonderful, because there is something to just be said for human compassion and for a person feeling like another member of their community cared about them and made a connection. So when people ask me, should I give them money? I'm like, totally up to you. When I give someone money on the street, I do not have high expectations of remedying their problem with them. It's just so they know I saw them and I heard them. I try now to buy food if I can, but whatever it is, it's a personal decision of how I want that person to think I saw them and I noticed them. I think it has nothing to do with serving their longer term homelessness or interest. That's just my personal view. And so I'm very supportive of giving people meals and doing all of those things. I think it's a very difficult personal choice that I probably would not make, to try to give them actual intervention help as a non-professional if you haven't been trained and you don't have a team to back you up. Because if they do lose their temper, if you get too close to them and they, it can not only be a very negative experience for the volunteer, which literally stays with them their whole life and changes their view of the homeless population forever, but obviously also a very negative interaction for the client. And so my suggestion would be is when you go beyond the, hey, can I buy you a cup of coffee? How are you doing today? Some people know the names of the person and just check on them. Or you should find your local service provider and let them know what you know about this person and be able to give them a detailed, informed, his name is Bob, he's 43, he's a vet, I think his wife died, he hangs out here on Saturdays, he gets very upset when whatever, and asking them to help you with the harder stuff, helping them get their birth certificate and their documentation. That's how I run a homeless shelter, and my family will tell you, I don't hand people a card and say, come into our shelter. I will go back to the office and tell our outreach staff, hey, I saw someone under the bridge and his name, but I don't feel like I'm qualified to make sure that interaction is a win for him and a step forward in our journey to build trust. So I don't do that. So I don't think I completely answered your question, but I think the people that we were helping are people who've been coming to our soup kitchen for years, and this person's chatting with them for weeks before she gets them to tell her that what they need is their birth certificate, and she's built that trusting relationship where they're willing to take her to their former house with their former boyfriend. That's a long process from someone who's done this for many years. I wouldn't attempt it. There are many wonderful volunteers who do it and do it successfully, but that's not how I would advise people. I would say, be human, be a community, make them feel cared about because they feel like are garbage. But when it comes to figuring out what the next step is, consider bringing in someone who's trained in and what's best for them and how to engage with them. Okay, can I take this young lady before the dean and then?
Hi, my name's Avery. I work with returning citizens in a couple different programs in the past 7 months or so, in transitional housing settings and also in the community. And I just wanted to ask, you kind of mentioned about working collaboratively with other systems. And what we find often is that working with probation and parole presents a lot of challenges for us, whether it be violations to probation and parole, and having those be kind of non-negotiable based on people's stipulations or conditions. But then also on the housing front specifically, people being stipulated to certain kinds of housing and having that be also non-negotiable. Most recently, I had a client who had been incarcerated for 27 years and was on parole until April, and we had been working towards on a housing application, and he was finally accepted to the housing, and no one had said to us that he was required to go to a sober home, even though he didn't have any history of substance use, and no one was budging on it. The way the condition was even written, it was kind of clearly interpreted in one way, but by the parole board differently. So I'm just wondering what your experience is, and if you have any suggestions of working alongside those.
Two thoughts on that. One, we have a great relationship with our local police. We are struggling with our probation and parole department, who literally drop people in shackles at 10 o'clock at night with no information, and trying to work through that. They claim a lot of it is that they find out the day before the person's being released. I find that shocking, given that they've been with them for 5 years. You figure they figure it out. But what's interesting is in our community, I learned that there is a state rule that the Department of Social Services has to be consulted before someone is released into a community to identify the most appropriate housing placement. And so even though they still do it, they're not allowed to bring that person to the shelter. If I wanted to, I could say no, but I don't know what they would do with them. Because there's supposed to be a conversation that happens at least 48 hours before they're released about where they're going to go in the short term and in the long term. I don't know if you have any kind of statute like that, but it'd be worth figuring it out because it gives you some leverage. And then that's the kind of thing I think for policy change, whether it's legal action or getting a civil rights organization involved, because they need to understand that is literally just making the person homeless. And we have this issue in most cases with sex offenders, where there are all these zones that they're not allowed to live, and they're conveniently in all the affordable places. And so, I'm not going to be able to put them on a 3-acre farm in Bedford, and there's literally functionally no place for them to stay. So that there is a true bias against people don't want these people in their communities, and they work very hard to keep it that way. But then the system that cares about homelessness has to engage and push back and have a plan.
Thank you.
Go ahead.
One more question. Happy to see you. And maybe one last question. Then I will ask the last question. That's fine. Thank you very much. That was actually terrific. So you are running a homeless shelter with the end of ending homelessness. So what kind of people are you hiring, and how does that hiring, sort of that introductory conversation go?
It's interesting. So I wouldn't say that we've really changed the profile of the staff on the ground. And it was an adjustment for me because my career is not, in the nonprofit sector originally. We are not asking people about their email writing ability and their reporting and their spreadsheets, all of which is really important, but we're really focusing on their humanity, their ability to connect, their persistence, and honestly, their ability to survive in a job like this where there's a lot of disappointments for every joy. And so that hasn't really changed, and the super employees are just unbelievable, and the ones that are just phoning it in are really damaging, and it's a real struggle to figure it out and move people quickly and really have the right people, because this is not like other forms of social services, and we're starting to realize if someone has not worked with the homeless population before, you almost shouldn't bother. Although we are taking some college students that have a lot of passion for the work. Where I've tried, and we don't have a ton of resources to hire sort of back office folks, we are trying on the management team, and including the management of the social services programs, to try to bring people with a little bit more of, because most people in social services who are supervisors were the superstar case manager that got elevated. And they're amazing at that part of the work, and it's a very important part of their management role because they're dealing with challenging clients, they're advising their staff on problems, they're going to back up a case manager on a difficult situation. But that what they were not good is thinking about some of these strategically, thinking outside of the day-to-day about program design, or they're also just used to being starved of resources. They're not used to asking for stuff, which for those of you who ever worked in the for-profit sector is not a problem. So they don't say, hey, if I had this, I would be awesome. Or, you know, when I got there, I used to laugh my email. I would see a little green bar when I sent an email, and the computer would freeze, and 45 seconds would go by. And I was like, oh my God, that's 45 seconds that you know, this was going on for a decade, and it never occurred to anyone to say we have to have new computers. So we're trying to bring staff at the senior levels who are just a little bit more able to step out of that unbelievable passion and commitment and just grinding it out day by day in the field to kind of come back and say what would make it better, what data could we be looking at, what partnerships could we be creating. So we're trying to bring in a different skill level there. And some of that's education, but a lot of it is just looking for people who have been in environments where they've managed projects, or they've been responsible for budgets, or they've implemented new programs. So looking for that innovation